I'm John Schroeder. Two important developments in the field of cardiovascular medicine have occurred in the last 10 years, which will have important impact on how you approach your patient with angina pectoris. One advance is the new appreciation that inappropriate increases in coronary tone or vasomotor tone can produce angina in patients with a wide range of anginal syndromes. Secondly, the new availability of a class of cardiovascular agents called calcium entry blockers or calcium antagonists, which are potent coronary vasodilators, predict that these agents will play a major role in anti-anginal therapy. Today, I'd like you to meet some of the key figures who have performed the research in the field of calcium entry blockers. Dr. Robert Zelis, a cardiologist and vascular smooth muscle physiologist. Dr. Robert Bruce, a cardiologist and exercise physiologist. Dr. Arnold Swartz, professor of pharmacology and cell biophysics. And finally, Dr. Peter Poole, who has had extensive experience in the treatment of angina pectoris. Calcium channel blockers are a remarkably varied group of drugs which possess potent vasodilatory effects and, in some instances, significant antiarrhythmic effects as well. These agents possess a number of potential uses, but our current interest is in their application to the patient with angina pectoris. One reason for this is that our current understanding of anginal syndromes has changed considerably. Dr. Zelis explains.
Cardiac pain occurs when there's an imbalance between the oxygen requirements of the myocardium and coronary blood flow to supply those requirements. How can we diagram this? Well, we can think of myocardial oxygen consumption and coronary blood flow as being on either end of a teeter-totter. When a person exercises, the oxygen requirements of the myocardium increase. Normally, coronary flow increases to the same extent. In a patient with coronary artery disease, coronary blood flow reserve is compromised. So when oxygen requirements go up, coronary blood flow cannot increase appropriately, and angina results. Now, this is one mechanism by which angina can occur. But what about angina at rest? Prinzmetal's angina, or variant angina, is thought to result from coronary artery spasm, a transient narrowing of a large epicardial coronary artery, usually associated with ST segment elevation. At one time, we used to think that this was rare, but in fact, it isn't. In fact, it may occur in 1/4 to 1/2 of the patients admitted to hospital with rest pain. Now, what's changed our thoughts about this? I think the primary thing is that we now realize that spasm is usually superimposed on coronary artery disease. Since spasm is the problem, these patients usually respond to calcium blockers, which is remarkably effective in preventing the spasm.
Okay, all the tests, Mr. Webster, are negative. We've really not found anything. Your stress test is negative, and everything we've seen so far is negative. I think the next thing we have to think about is a heart catheterization. The trigger that causes coronary spasm is not really well understood. Some people think that it's an overactive autonomic nervous system. Some people feel that the blood vessels overreact to a physiologic stimulus because there may be too much calcium within the blood vessels to begin with. You may have a different kind of angina. And a type of angina that we usually see comes on with exercise. You may have coronary spasm, and I think we can get down to the bottom of it with a heart catheterization.
If that's what's needed, then...
Shot now, okay, ready? Inject. Okay, that's it. There it is, spasm. Okay, how you doing? Any pain?
Yes, it hurts.
Give him the nitroglycerin. Ready? Inject. Okay, look at that. Get the focal spasm there, okay? The rest of the vessel looks pretty good. Any better now? Is it starting to get any better? Little pain?
A little bit, very little. But
okay.
There.
Getting, how's it now?
Getting a little better.
How's EKG?
And we're baseline.
Nitro's in. Okay, one last shot. Let's take a look. Ready? Inject. Good. Okay, good. Spasm of the right coronary. Okay, I think we know what the problem is.
The application of coronary arteriography in patients with angina has helped us to understand how increases in coronary vasomotor tone may produce angina. The arteriogram that I'm going to show you helps illustrate how transient occlusion and due to spasm can produce angina in susceptible patients. This patient developed severe angina during the coronary arteriogram. During the injection of the right coronary artery, there was observed to be severe diffuse spasm. The patient was then given nitroglycerin, and on repeat injection, there was noted to be focal spasm, as can be seen here, reflecting a hypersensitive area of underlying coronary disease. Further intracoronary nitroglycerin then revealed a completely normal coronary artery with only minimal plaquing. Now, although this patient had relatively normal coronary arteries, you can observe the same thing in patients with severe or moderate underlying coronary artery disease. And this reflects the fact that a wide spectrum of patients with coronary disease or normal coronary arteries can have angina due to increases in coronary vasomotor tone or coronary spasm. At the University of Cincinnati College of Medicine, Dr. Arnold Swartz has been investigating the action of calcium channel blockers at a cellular level.
The mechanism of action of calcium blocking agents is very, very complicated. Part of the complexity of this is due to the fact that the chemical structure of the drug molecules are completely different from one another. This means that they have important dose-dependent differences, pharmacologic differences, biochemical differences. They have different effects on different tissues as well. Yet, in spite of this, there is a common thread that runs through all of the drug molecules. They all inhibit calcium metabolism, and they're all very powerful inhibitors of coronary spasm. Coronary spasm, what is it? What causes it? The molecular defect involved is unknown, but most people feel that some defect in calcium metabolism at the cell membrane plays a most significant role. Let's return to fundamentals and review the molecular processes involved in contraction and in relaxation of all muscle types. Calcium is the key cation that links the process of depolarization to contraction in skeletal, vascular smooth, and in heart muscle. Let's examine the situation in vascular smooth muscle and look at a coronary artery cell. Here is a cross-section of a coronary artery. This is a normal one because it is free from blockage. The other one is occluded with plaque. The encircling wall of each artery shows nerve endings, overlying connective tissue, and smooth muscle cells. When the cells contract, they narrow the diameter of the artery and cause a constriction. Closing in further on a section of smooth muscle cell, we see part of the cell membrane, which is called sarcolemma, the cytoplasm or the matrix of the cell, which we call sarcoplasm, and connective tissue, and a nerve ending. Notice the action potential. It's visualized as an electronic pulse which courses along the whole membrane, successively causing changes in permeability. This is known, of course, as depolarization. At the various points of this change, the membrane opens up, a gate opens up, and calcium enters the cell. We call this a potential or voltage-dependent channel. Another and perhaps more important physiological mechanism of activation involves a receptor-dependent mechanism. Now, this nerve terminal has varicosities, and inside the varicosities, norepinephrine is stored in granules. The granules release the neurotransmitter upon activation by an action potential. The norepinephrine moves in this space between the nerve terminal and the cell membrane, locks into position in its own special receptor, for instance, an alpha receptor. As it locks into this alpha adrenergic receptor, a gate or pore opens up in an adjacent position in the membrane, and calcium then is believed to enter the cell. Again, this is called a receptor-operated channel. When calcium enters the cell, it causes contraction in one of two ways. It releases a storage of calcium from an internal site called the sarcoplasmic reticulum, and the second and more important way, it activates an intracellular protein called calmodulin. This activation results in an exposure of certain hydrophobic sites, which then allow the molecule to interact with yet another protein called myosin light chain kinase. This then becomes an activated complex which phosphorylates or transfers phosphate from ATP, adenosine triphosphate, to the light chain surrounding a myosin head. The activated or phosphorylated myosin head then can interact with an actin fibro, causing a sliding motion to take place known as contraction.
We found that the contractile mechanisms in vascular smooth muscle are quite different from cardiac muscle. Cardiac muscle is fast. Its contractions are measured in fractions of a second, whereas smooth muscle, seen here, even the initial rapid phase is relatively slow, fractions of a minute. And in fact, you can think of smooth muscle as either being in a state of contraction or relaxation. In patients with coronary artery spasm, the contraction is much more sustained and much more prolonged.
We talked about the regulation of vascular smooth muscle contraction. Let's speak for a few moments about the heart. Now, like vascular smooth muscle, the heart requires calcium for contraction, but the source of calcium in the heart is primarily internal. With each beat, a small amount of calcium comes into the heart cell, concomitant with the action potential, and releases a burst, a large amount of calcium, from an internal membrane source called the sarcoplasmic reticulum. This is not the case in vascular smooth muscle, where calmodulin represents a primary control. Not so with heart muscle. Because of these differences, heart and vascular smooth muscle would be expected to react differently to drugs that affect calcium. Now let's consider, for example, a relatively pure calcium blocking agent, Diltiqazem. We believe that Diltiqazem sits in or plugs up the channels that permit calcium to flow from the outside to the inside of the vascular smooth muscle cell. This occurs chiefly in disease states where a lot of calcium would tend to come into the cell, and if so, might cause a coronary spasm. Diltiqazem also sits on the heart cell membrane as well, in similar channels. But remember that heart is rather different from vascular smooth muscle. The source of calcium is different, and the control is different. Now, what does all this mean? You can select a dose of Diltiqazem that produces a significant relaxation of coronary vessels without producing a negative inotropic effect on the heart.
There's a number of reasons to be excited about the calcium channel blockers. Besides preventing coronary spasm, they also produce a number of secondary hemodynamic effects. They decrease heart rate, they decrease blood pressure. So when you give them, you ought to get a decrease in myocardial oxygen consumption as well as an improvement in coronary flow. So they ought to be effective in the treatment of exertional angina as well as variant angina.
The use of Diltiqazem in the treatment of patients with angina pectoris has been studied extensively. Here at the University of Washington School of Medicine in Seattle, Dr. Robert Bruce, Dr. Ken Hosick has studied the effect of Diltiqazem in patients with exertional angina. Dr. Bruce?
We found that Diltiqazem, as a single dose orally, significantly improves exercise capacity, duration, and prolongs the onset of the appearance of chest discomfort, anginal pain, as well as the ischemic ST response of myocardial ischemia.
Any idea about mechanisms?
We evaluated 15 patients with exertional angina, and in order to do this, we inserted Swan-Ganz catheters and arterial lines and had the patients exercise.
How were these patients profiled?
Roughly half the patients showed a normal response in pulmonary capillary pressure with a little increase and symptom-limited maximal exercise, whereas the others showed a significant rise, well above 16 millimeters of mercury. When they were retested with the oral Diltiqazem, we then found that the second group showed a fall in the elevated pulmonary capillary pressure, which was essentially normalized.
I see. How about exercise performance?
In both groups of patients, we found that exercise duration was prolonged after Diltiqazem, and the number of patients reporting angina was also reduced. Interestingly enough, we found that in the group 2 patients with the marked exertional left ventricular function, the cardiac output was improved at maximal exercise as well.
So it's effective in patients with stable exertional angina, and it actually appears to be safe in patients who have exercise-induced left ventricular dysfunction as well. What are your thoughts about other mechanisms involved?
Well, it seems to be safe in the sense that with a reduction in pulmonary capillary pressure, contrary to our expectations, we actually observed improved left ventricular function as manifested by an increase in stroke volume.
I see.
In fact, I think in this group of patients there was a 16% improvement in maximal cardiac output.
What are your thoughts about mechanisms?
I think one mechanism that we clearly demonstrated was having an effect was the reduction in pressure rate product at submaximal workloads, and clearly this was contributing to the overall improvement in both groups of patients.
So that's on the demand side of things. Were there any other anti-anginal mechanisms involved?
Yes, there may well be. As we see in this chart here, the relationship between pressure rate product on the abscissa or horizontal axis and the ST depression shown on the ordinate or vertical axis. The slope at rest in submaximal maximal exercise in the control situation is like this, and after giving 120 milligrams of Diltiqazem orally and repeating the same exercise protocol 1 hour later, the slope of the relationship is changed up to here. Putting it in a different way, if we had a given workload of 125 as the pressure rate product or work demand on the left ventricle, you get this much ST depression. But after treatment with Diltiqazem, there is much less ST depression.
My colleagues here at Stanford and I have performed a number of both basic and clinical studies of Diltiqazem. The heart transplant program at Stanford offers a unique source of human heart which we have studied. In vitro studies of these heart tissues have demonstrated essentially no negative inotropic effect at therapeutic blood levels for coronary spasm.
And what we have found is that Diltiqazem has a preferential mode of action. That is, at a particular dose at which it blocks the entry of calcium into the smooth muscle cell, wherefore it will be effective in the treatment of spasm, it has no effect, or very little effect, on the myocardial tissue. So therefore, Diltiqazem most likely can be used safely in patients who have coronary artery spasm, who have mild to moderate left ventricular dysfunction. This is an example of a recording from our muscle bath using one coronary ring segment from the human heart. And here what we've done is add potassium to cause contraction of the coronary artery. Once we've reached equilibrium, we then add a concentration of nitroglycerin, and as you can see, there is immediate relaxation. However, no matter how much nitroglycerin is added to the bath, this is the maximum amount of relaxation that will occur. Then we come here and add Diltiqazem, and as you can see, although it takes slightly longer to see an effect, Diltiqazem will cause further relaxation, so that the patient can then be treated with two agents that work by totally different mechanisms of action.
Now, what about combining this drug with beta blockers? Our experience, clinical studies, as well as experience from Europe have indicated that they can be safely combined and are remarkably free of problems. However, since the potential for heart failure exists, they should be combined with caution in patients with congestive heart failure. Diltiqazem is known to prolong AV conduction. And electrophysiologic studies in 15 patients at Stanford, similar to the one going on here, has demonstrated there is modest increase in AV nodal refractory periods. So certainly this drug does need to be used with caution in patients with heart block or sick sinus syndrome. The safety and effectiveness of Diltiqazem has been evaluated in several clinical trials for exertional angina. Dr. Peter Poole at the University of California in San Diego has been one of the principal investigators.
When Mr. Glass first came to the office, we were seeking to avoid coronary bypass surgery. As a result, we designed a medical regimen for him, which consisted of sublingual nitroglycerin, isosorbide dinitrate, and propranolol. As a result of taking these medications, we had some side effects that were involved, and perhaps you could tell us about those, Mr. Glass.
When I first started taking the isosorbide, I experienced considerable headaches. In addition, the Inderal caused a reduction of mental capabilities.
And that led to what?
I was unable to continue walking, as I mentioned, and I cannot exert myself to any great extent.
Can you think of any other side effects that might have been associated with those drugs?
Also, cold hands, and a definite reduction of stamina I was constantly fatigued. I am constantly fatigued, as a matter of fact.
And how about when you actually get angina and you go about taking sublingual nitroglycerin? Do you have any problems with that?
When I take the nitroglycerin, I experience a rush of blood to the head and also some headache. And until the pain, chest pain subsides.
Because of all these side effects, the calcium antagonists appear to be a promising new mode of therapy where the side effects we hope will be minimum and where these kinds of side effects we've just talked about will not be seen. To evaluate the effectiveness of diltiazem in chronic stable angina, we undertook a multi-center treadmill exercise evaluation in 57 patients using 3 endpoints: total time of exercise, ST segment depression, and the time to the onset of angina. We also evaluated 3 different doses, 120, 180, and 240 milligrams per day, and found a dose-related improvement in exercise tolerance with the best response at 240 milligrams per day. For example, at the 240 milligram level, time to termination of exercise increased from 9.1 to 9.9 minutes. The mean time to onset of pain was 8.2 minutes during placebo and 8.9 minutes during diltiazem treatment. And as for time to 1 millimeter of ST segment depression, 7.4 versus 8.2 minutes. In my own subset of 15 patients, the results were even more impressive. For example, the time to onset of angina was prolonged from 8 minutes on placebo to 9.8 minutes in those on 240 of diltiazem. Looking at mean time to 1 millimeter ST segment depression, the times for diltiazem and placebo were 9.1 versus 7.8 minutes. And as for the mean time to termination of exercise, the time increased from 9.9 to 10.8 minutes. The incidence of side effects from diltiazem in the multi-center trial was amazingly low. In fact, 1.5% of all patients reported any side effect at all, and that was headache. There were no laboratory-related abnormalities, whatever.
How long have you been on the drug now?
About 2 years. Over 2 years.
Long time.
Yep.
That's really good.
Seems to be working fine.
When you started out, how far did you go on the treadmill the first time?
About 9 minutes, a little over 9 minutes.
And most recently?
Almost 17 minutes.
17 minutes.
And the only reason I got off is because my legs got a bit tired. It wasn't due to the angina.
So what this all means is with the calcium antagonists, we're really able to produce a situation where people can do just a whole lot more exercise. I mean, like you've almost doubled your exercise tolerance. You don't have your angina anymore.
No.
And we're not dealing with any side effects.
And I'm getting wet.
Always had angina, maybe 3 or 4 days after starting the placebo. I'd have angina, and then I'd have more angina and more. And on the drug, I don't experience angina at all. I couldn't walk a half a block without having a severe angina attack.
I remember 2.5 years ago when you first came in here, you made approximately a minute and a half of stage 0 of the Bruce protocol, and now you can complete well into stage 3.
Yes.
It's really impressive.
Just tremendous. You have no idea how great it's been.
Changed your way of life.
It certainly has.
You have to take the nitro, you know, in order to alleviate the angina pain.
Sure.
But not as much as I used to. In fact, I'm carrying the same bottle around for a long time now. I take maybe 1 or 2 a week.
How many did you used to take a week?
Well, maybe I took 2 a day.
That's right. That's what I remember.
Yeah.
Before you started on this medication.
Except that I get a test by bike riding. And I know I live in a hilly area, and I know what hills hurt me. And they don't hurt me like they used to. I have much more stamina. No, I swear by this stuff. I wouldn't give it up. Whatever it takes, like today, whatever it takes, I'm yours to keep on taking the medicine.
Okay. Fasting 14 hours, no alcohol 2 days before.
Okay.
We'll come in, we'll draw your blood, and we'll have it back in time for your appointment.
Some of the patients in my subset were carried longer for a 4-month medium-term study, and some for a long-term study lasting 12 to 16 months. I can summarize this experience by saying that diltiazem, taken over a relatively long period of time, has a clear-cut, sustained therapeutic benefit, and in our experience is essentially free of side effects. The studies I've just described are compatible with diary studies and also with other treadmill studies done both in the United States and in Europe.
I was one of the investigators in a multi-clinic randomized double-blind trial of Diltiqazem versus placebo for variant angina. Two dose levels were used, 120 milligrams and 240 milligrams per day, in 48 patients with variant angina, 16 of whom had had a prior myocardial infarction. When 120 milligrams of Diltiqazem was compared to baseline placebo, there was a 41% decrease in angina frequency, and 19% of the patients became pain-free. At the 240 milligram dosage, there was a 68% decrease in angina frequency, and 30% of the patients became pain-free. Both of the doses were quite well tolerated. In fact, adverse side effects were reported in less than 5% of patients, which is funny because it's even lower than the placebo. When we've done these double-blind controlled studies, you know, looking at placebo and drug, about 15% of the patients on placebo complain of adverse side effects, and 5% of the active drug.
Why do you think that the adverse side effects are so much lower in the medication?
Well, it's hard to believe. What we think is happening is when the patients are free of angina or have less angina, they just generally feel better and maybe don't notice the other little aches and pains and problems that always go on in a person's body. Clearly, I think Diltiqazem has an excellent safety profile, perhaps because it's a more balanced calcium entry blocker with relatively few non-cardiac effects.
I think that these drugs are extraordinarily exciting. They're the drugs of the cardiovascular drugs of the 1980s. This decade is going to see a tremendous explosion in the use of these agents. And the reason is no accident, because calcium represents the key link between processes that excite and then produce something like secretion or contraction or vasodilatation. Calcium is always involved. And when you alter the metabolism of calcium, then you alter the reactivity of the tissue.
So, as you've seen today, myocardial ischemia results from a complex interplay of changes in coronary vasomotor tone and occlusive coronary artery disease. The unique pharmacologic properties of the calcium entry blockers now provide a balanced therapeutic approach to the patient with angina pectoris.